Uh, I enjoy this conference especially because of the collaboration of all the people involved in trauma. And we get to speak to physicians and nurses and emergency room technicians and people who work with radiology, surgeons and medical doctors and pain specialists. And it's a rare opportunity to work and talk with so many people with different levels of expertise and also to learn from each other. I'm going to speak for a few minutes about a little bit of orthopedic history that helps us all understand how to take care of patients in trauma. And the history is very short. It's not like Cartagena, hundreds of years, right? I'm only going to go back as far as my lifetime. I was born in 1970. And so this is a very short history of orthopedics and the care of trauma patients. We're going to talk about what we call early appropriate care. That's where we're going to get to, but we have a couple of things to talk about before we get there. So a couple of comprehensive statements always come to mind when we're talking about polytrauma patients that we sometimes take for granted because we've developed a teamwork for taking care of patients that's so critical. So I'll just read these. The outcomes in trauma patients is improved when care is delivered at a trauma center. Now that's not profound science, but it's still something we have to remind ourselves always because we start taking care of the patient at the field, like we heard earlier about when the patient gets scooped up from the street and we bring them to the hospital. Getting them to the trauma hospital from the outside hospital is extremely important to get them the timely care from all of you, right? Because we all do better as a team when the patient's in our trauma center. And having an established and optimized trauma system is essential to improve the outcomes of those who sustain high energy extremity trauma. One of the first conferences we held here together was about establishing protocols and understanding the common ground where we operate and work together to take care of patients the same way. And that's the benefit of the trauma center, to take care of someone the same way every time. Expect it, make small changes to improve the patient's care together. So where does this start? Well, Trunky talked to us about epidemiology of how patients don't do well when they have a trauma mortality. And we heard a little bit about this from Julian earlier today about acute mortality, secondary mortality, and tertiary mortality. And the acute mortality is what Mustafa was talking about before. Patients who have a severe head injury, a major hemorrhage, traumatic hemorrhage and shock in the field, cervical spine injury, central nervous system trauma, airway obstruction, cardiac events in the field from sudden cardiac collapse, major thoracic trauma. These things most of us don't get to see because we're not in the field picking up the patients. People die in the field before they even come to us. But what we're going to focus on for this lecture and for a lot of our discussions in the next couple of days is really about secondary and tertiary mortality. And the secondary mortality is within hours. And these are things we might be able to control. Again, hemorrhage is a leading cause. Hemorrhagic shock is one of the things, it's at the top of our mind always when taking care of an orthopedic patient, a polytrauma patient. Pneumothorax, cardiac tamponade, where to put the needle, that's always evolving. Hemothorax, abdominal injury, pelvic fracture, my specialty, and then long bone fractures, which is the meat of where we get to things that we can control. But things really continue to get worse for some patients in days or even weeks after the trauma occurs. And this happens for other reasons, things we might really have the ability to control in the patient's future. Sepsis, gross infections, cardiopulmonary failure, pulmonary complications, and multi-system organ failure. And that's where most of what I'm going to talk about is really focused today. So as an orthopedic surgeon, one of the first slides I had in a lecture from the first conference I attended here was, where does the orthopedic surgeon stand in the trauma team? And it's way back in the back of the team, the anesthesia and general surgery, trauma surgery, nursing, emergency medicine, right? And the orthopedist is waiting, just waiting for his turn, right? But we have a role. We can take advantage of what we know and emphasize things we see that we can make the patient's care better. We can help decrease their blood loss. We can decrease their pain by stabilizing their fractures. Decreasing their pain will decrease their analgesic requirements that we just heard about and help stabilize the amount of narcotics and overall anesthesia they need. And then also by establishing stable fractures, we can get them out of bed, move them better so they don't have clotting disorders in their extremities and gross infections in their lungs. So this is where I want to help the patient get better every single day. So I'm thinking pelvic fractures. I'm thinking open fractures of the extremities. I'm thinking about this patient who's got long bone fractures and near amputations. This is one of my patients who was hit by a train in downtown Baltimore. And everything I can do to help these patients, here you see a couple of things that can affect their resuscitation and the overall immediate outcome of that patient in the first couple of hours and even days. So here you have another patient who's got many injuries. He's got long bone injuries. He's got articular fractures. He's got some spinal trauma. He's got a lot of skeletal disease. And that's what you can see on an x-ray, but you have to assume that he's got abdominal trauma and CNS injury and lots of other things too that I know nothing about. But when do we intervene? When do we do things to help advance this patient's care? Well, this takes us back to the 70s. You know, us putting rods in femurs and long bones really didn't start until the 70s and really started to accelerate in the 80s. And we didn't know all about what we were doing. We didn't know about the benefits and the negative impacts we could have on our patients. And often when patients came in, people thought they were too sick to get orthopedic care. And we saw people not do well in the first few days as we waited to do their surgeries. And in the 70s, that's when we started to think about how can I make this patient's care better just from doing things at the right time, not by doing the right thing, but the right time. So this is an interesting study, but done by an interesting surgeon. His last name was Bone. I like that, right? And so Larry Bone, when he was in training, he did an aggressive study of 180 patients, and he would go and draw blood from them and test them and see how they did and follow them over the course of months and years. And he found that patients, if you divided them and fixed their femurs in less than 24 hours, or if you took a second group and fixed them after 48 hours, the ones you fixed early did better. And this is one of the earliest studies in 1989. Now that's getting close to the time of when some of you were born, right? And some people did better because they were fixed earlier. They had less ARDS, they had less fat embolism because of the rods we were putting in, they had less pneumonia because they got out of bed earlier. This helped improve their ICU stay. They were in the ICU less time and the number of days on the ventilator, and their hospital stay as well. And so all of the administrators were saying, this is a bonus. This sounds like something good. We support this. So of course, this needs to be verified. And this is a 10-year prospective study of over 1,000 patients doing the same thing, right, in a different center. And they found quantitatively significant numbers of decreased pneumonia, pulmonary embolism, ARDS, decreased length of stay, ventilator days, and costs. $59,000 on average for these patients. That's a lot of dollars. And so this is starting to take a lot of attention, and people are starting to think about, well, how can we make things better? And this is in the 2000s. So other people thought, well, you know, why are we thinking about femur fractures? Well, femurs are a good marker for polytrauma. Femur fractures are common. They're not a fracture that's easily stabilized with a splint. So that was one of the early ones that we could put an external fixator or traction in. These were surgical interventions. So it really was a nice model. And it's also a fracture that happens in polytrauma a lot. So it's a good indicator from an orthopedic standpoint of what we can do better. But some surgeons, like Dr. Valier, really started to take this idea one step further and say, what can we do with all fractures from all skeletal injury and make things better? And so their group started to think about coming up with different protocols for taking care of everything all at once. Okay, and so they took care of pelvis fractures and hip socket acetabulum fractures and femur fractures, of course, and spine fractures as well as accelerated surgical protocol. And they did better. Again, hospital stay, ICU, overall complications, pneumonia, ARDS, and systemic infection all were less in their patients when they were treated earlier. So this is looking very promising to fix people. Okay, but they concluded at the end of this, surgical timing must be determined with consideration of the physiology of the patient and the complexity of the surgery. We can't forget the patient, right? We just heard a nice lecture about each patient experiences things individually. Each person experiences polytrauma individually as well. And parameters, hopefully some science, should be established within which it is safe to proceed with fixation. So still looking for that holy grail of when to fix fractures at the right time. And they found that some people didn't do quite as well with early fracture care. And it wasn't always clear. There were some groups who had pulmonary injury and head injury that really didn't do well. And I remember going through my training in the early 2000s, and we said, well, it's not all head injury and it's not all pulmonary injury, and we have to figure this out. But what we did notice, and looking back at the data that Dr. Bone collected, trauma, polytrauma, causes increased and sustained inflammatory symptoms and responses in the body that we've measured. And looking back at Dr. Bone's data, they found that the patients with increased inflammatory markers actually did worse. So maybe we should start looking at that a little bit closer. And so it came up with this idea of the systemic response to trauma. And this is an orthopedist interpretation of science, right? Two simple lines, very, very easy, very simple. The green one's the normal trauma response. When a trauma comes in, the inflammatory mediators are released, and then there's a rebound effect where we're susceptible. And we started to think about, well, we notice when we fix people at the wrong time, their inflammatory mediators go even higher, and that creates a deeper rebound, and patients do worse. Now that's oversimplified, but it's an idea to think about in looking at these patients. And why does this happen? Well, we cause damage too, right? We cause problems. We cause bleeding, hypothermia in the OR. I love my OR about 32 degrees. And surgical trauma of damaging the tissues, increased shock, local shock right there. And this causes another increase in the inflammatory reaction just from the surgery alone. So if we do this at the right time, we can trigger increased pulmonary complications and increased ARDS and other multi-system failure, which is even worse because we did it at the wrong time. So we've heard a little bit about this in our first lecture today about damage control. The idea was sort of taken from the Navy, because I don't know how much you know about Navy ships. I'm an Air Force guy, but I'm told the ships have certain compartments. And if they get hit and damaged in one part of the boat, they can close off that area so that they can get back to port. So they call that damage control in the Navy. It's a whole specialty of how to take care of a ship that's failing, and that's someone's job. But the whole idea of the damage control, the opposite idea is to minimize our surgical trauma, minimize the inflammatory response to the trauma itself, minimize blood loss, improve the pain without doing too much of an intervention, and then still promote mobilization. These are the same things I've talked about, how I can affect a patient in orthopedics. And most of the time, we are talking about splinting and traction and external fixation through the skin. No one likes it, but it seems to have a good effect. But one of the greatest advances just in the past 20 years, now we're moving into the mid 2000s, around 2002, 2005, was the use of a sheet or a binder effectively to close the pelvis and tamponade and cause a stabilization of the patient's blood loss so that the patient can improve and decrease their inflammatory reaction. So this whole idea started with damage control orthopedics, damage control trauma care. It's sort of, the idea has taken over into different subspecialties as well. And so femur fractures that were treated with damage control, with external fixation, in my training, we did it with traction. They didn't have that sustained systemic response. And the negative effects of delaying their surgery were not so bad. And some of these patients didn't do so poorly. And that was a good thing. So Dr. Pape started to look at this And he started to look at the inflammatory mediators we could follow, whether it's C-reactive protein or neutrophil elastase or the interleukins, just platelets alone. We can look at these things and study what a patient's response is. And so this became this group's focus. Now I was speaking to some of my partners just yesterday about this. It seems like we are developing centers where we have a specialty in how we manage patients. This is a European center that's managing patients that are taken care of in the, what do we call it, the Franco-German way of scooping and running with patients and trauma in the field. And maybe they smoke more, and maybe that's not the same population who's getting damage control orthopedics. And in the United States, it's earlier care, earlier total care with Dr. Bone in Buffalo, where he's getting ski injuries. Maybe the patients are a bit different, and we develop pockets of how to take care of patients. And maybe we're not studying things the same way, but we're studying things going forward for sure. So there's another study that looked at scoring systems. We heard a little bit about scoring systems before. There's the sustained release of inflammatory markers with early total care. It's not seen with the DCO like we talked about. And there's no increased multi-system organ failure with DCO in patients who had increased SIRS response. So then what do we do about the timing of care? We still want to give a patient early total care, or as early as possible. But there are these patients we still have to figure out who's not going to do so well, and who should get damage control in that situation. How do we choose? Now we have all these camps of people who take care of things different ways and say, this is the way. And so how do we choose? Well, we have to think about things as the borderline patient. This is Dr. Pape in the European group again, saying we're going to think of people, a lot of people with different problems, and say we're going to take care of them with damage control. These are borderline patients. They're not good for total care. People with an ISS of 40, patients with polytrauma and thoracic injury, multiple injuries and abdominal pelvic trauma. You can see the list here. This is the group they consider that they found increased markers from an inflammatory response. And on the other side, where I started my work in Baltimore and where I live now at shock trauma, another camp was saying, well, we don't see that same response. We don't see people have as much ARDS when we do earlier total care. And we're not seeing that same group. They said their borderline patients are closed head injury, poor respiratory status when they're being resuscitated, and poor resuscitation response in the first 12 hours. All right, so their considerations were less. So the main consideration now, the main argument now is looking at what tells us whether someone is resuscitated enough. Well, there's a number of studies, and I didn't want to go too much into it, but it turns out that someone who comes in with a very high lactate on admission is at high risk for complications. People who have a lactate that comes down with resuscitation actually don't do quite as badly, and that doesn't correlate. Their absolute level around the time of surgery doesn't correlate with their outcomes if you do early total care. But what does prove to be a good marker is a decreasing lactate level as you resuscitate them. That's a good prognosticator for a patient who's ready for surgery. So that's something to keep in your back pocket. So it's interesting that the Valier group in Ohio decided, well, we're going to try to set up a protocol. This is what we talked about years ago together, right? We're going to set up a protocol and data that's going to drive us to take care of patients the right way. And they said, we're going to decrease the narcotic use and all of these things that we've talked about so far. And one thing they noticed is there's a lot of people, just like all of us in this room, that have to get engaged to accept and buy in and decide they're going to cooperate. Now, we don't cooperate very well, very often, right? But it's really important that we try to do it as well as possible. And for this team, they had to get the trauma surgeons and the critical care ICU physicians, anesthesia and spine, and us bone docs to cooperate together starting in around 2010. And they came up with a protocol to take care of patients within 36 hours. We touched on this a little bit before. These are the criteria. Again, this is what Dr. Valier started to sell to her hospital at the time. Femur fractures, pelvis, hip sockets, spines, patients who are sick and who also had other systemic problems overall. So this is a sick group, and they said, we're still going to do it. We're going to see how well we do. We're seeing how well we can do, and then we're going to make some changes as we need to. So they did their definitive care. They did their aggressive care within 36 hours, if at all possible. Now, anyone could veto this, and you'll see that in a minute, but they were all trying to get this done within 36 hours. As long as their acidosis was improved, their lactate was coming down, their pH was stabilized, base excess was okay, then they would go ahead with the surgery. But if not, they would do the damage control like Dr. Pape decided. All right, so this is the team. This is like a heterogeneous group, lots of people thinking differently, but they have to come together as a team and provide this early total care, early acceptable care. So they had a study of over 300 patients. In the 40s was the average age, to ISS of 26, 346 fractures, and here you can see what it is. All right, a lot of trauma. It's a very busy trauma center. And here's the reasons for delay down here. Reasons for delay, surgeon's choice. We still could not comply, all right? You can see about 2/3 of the time when patients got delayed more than 36 hours is because I didn't feel comfortable with it. I don't feel comfortable doing the surgery. Sometimes the OR wasn't available. Sometimes the head injury was too severe. Patients also said no sometimes as well. And this is the population. They had a nice historical cohort because remember I talked about that study before where they've been trying to do this. And they said, okay, this is what we did before we changed our plan. And now we have others as well. And then they looked at their complications overall. And, you know, between the historical group and the test group, they didn't quite have enough people in their cohort with only 330 to actually get statistically significant data that were different compared to the historical data for pulmonary complications. But what they did see was with a delay of greater than 36 hours, there was an increase in sepsis and acute renal failure, as well as a worsening length of stay, ICU stay, and overall complications. But what they saw was that they could do it without an increase in complications in the first 36 hours. So they had made a step forward in most of their patients that they enrolled in the study. They had fewer complications in those patients, and the ones that waited more than 36 hours proved to be patients who didn't do quite as well. So what does this mean? Teamwork can work, right? We can establish a plan together. We can make a change and move forward. I like this study a lot. There are a couple of follow-on studies that say, look, we have a problem. We know what the problem is. There are many solutions. We're going to choose one and it's going to work. And then they show that it does. So that's, I think, what we all have the power to do, thinking together in a group as diverse as we are. All right. So the other thing that's nice about this is they didn't need anything differently. It was just the teamwork that got it together, and they didn't have to dedicate any additional resources to this task. So I think this study has driven us quite a ways into the future, right? It has to be taken with a knowledge of our past and what the risks are, an understanding of who the risk patients are, and to understand what could go wrong. But, you know, early total care and damage control, think about those things. Think about them as extremes and find out how to navigate that patient of yours to the right outcomes. Understand if your patient is a borderline patient, right? We used to think of all head injury as being a problem. Now it's really depressed skull fractures, midline shifting lesions, things like that that are a problem, increased ICPs that delay surgery. The same thing, Pape thought of pulmonary injuries at risk being pulmonary contusions. That was on the list, but it's not really that anymore. It's, you know, pulmonary injuries that require significant pressure, increased pulmonary pressures on the ventilator, flail chest, that kind of damage that has not responded to resuscitation. So think about what conditions can increase the complications in your patient. I'm not giving you a solution to this. I'm giving you a path forward, okay? And implementing this plan really takes collaboration. But I think all of us together can come up with a protocol in each of our centers that makes sense for the people we have and the resources, so we can implement early appropriate care in the right way.